Assalamu alaikum wa rahmatullah. Good morning, everyone. I need to declare a few things before I start. This is a case of stable patient. It is not an acute coronary syndrome patient. However, the implication of the case can be shared between the acute and the stable patients. Second, the way I have managed this case may not be the ideal way, just I will show you what we have done with this patient. So this patient was 70-year-old with a history of hypertension, and he came with a complaint of a chest pain that was very typical for angina. Now, although he is a 70-year-old, he was really otherwise healthy, and just by looking at him, you will never give him more than 50 years of age. He has an ECG that showed atrial fibrillation flutter, and apparently this was the first time to document this pathology. His echocardiogram was structurally normal. So this was the ECG that we saw in the clinic. The flutter waves are clear here, and because of his chest pain and his stability, we decided to subject him to an exercise stress test that was positive with ECG findings and symptoms at around 4 minutes into the regular Bruce protocol. So based on this, we decided to proceed with an angiogram. Now, in the clinic, I have discussed with him the potential need for anticoagulation. I mentioned the warfarin, and I mentioned the new oral anticoagulants. So this was his coronary angiogram. Okay. Now, the catheter we used during this case was a 5 French catheter, just to give you a reflection of how big these vessels are. Very clear here, there is very tight stenosis in the mid of LAD at the main septal branch. It looks long segment of irregularities here. I thought this might be the cause of his symptoms. Now, prior to the angiogram, I was thinking if this patient has a simple disease, and because of the need of anticoagulation, I'll put a bare metal stent, especially he is not diabetic. He has only hypertension. However, because of the size of this vessel, I thought I don't want to put a 2.5 bare metal stent into this artery, so I thought this might be a case of drug-eluting stents. And this what I did. So this is the result after a 2.5 everolimus eluting stent. So the result was good. However, this was not the only pathology he has. There was a lesion in actually a diffusely diseased right coronary artery. This right coronary artery is large, and there are multiple segments of mild irregularities. In the cath lab, we debated this lesion here. In the proximal segment of the RCA. Should we do it? Should we leave it alone? We did an FFR on this stenosis. It's okay. It's okay. We did an FFR that was 0.72 without adenosine. We debated if it was a correct reading. We did an IVAS, and it was very eccentric stenosis. That was kind of a pinhole stenosis in that area. So this also got actually 2 drug-eluting stents because of edge dissection that necessitate another stent. Angiographically, we ended up with nice results in both vessels. Now we came to the question of antiplatelets and anticoagulation. His CHA2DS2-VASc score was 2. That was because of the age. He was 70-year-old. and because of the history of hypertension. And Hazebleed was 2 as well. And these 2 came from also from the hypertension and the age. For Hazebleed, the age should be more than or equal to 65. So we talk about the dual antiplatelet therapy. The patient already did the homework and went and read about the warfarin and the other stuff. He told me, I don't want to be on the warfarin. Based on this, I decided to keep him on dual antiplatelet therapy, the aspirin, 81 milligram, the clopidogrel, 75 milligrams, and because dabigatran and rivaroxaban were the only drugs available to me at that point in time, I decided to start him on the smaller dose of rivaroxaban, 15 milligram once a day. And the reason is obvious because of the dual antiplatelet therapy. His GFR was more than 60. More than 60. 1 week after this, he came to the clinic. He said he has frequent attacks of epistaxis, and he has excessive bleeding while shaving. And it was really frequent, so it was a concern. So based on that, I decided I want to stop the aspirin and see. After stopping the aspirin, the patient did extremely well. The epistaxis has disappeared, and no more bleeding. Now, I decided that I will keep him on this, on the clopidogrel and the rivaroxaban for a year. Then I will stop the rivaroxaban. However, because of the, adding aspirin to anticoagulant will increase the risk of bleeding by 50 to 60%. So keeping this in mind, now my plan is to stop the antiplatelet therapy completely at 6 months, especially this guy came in electively. There's no thrombus burden. I decided to stop the antiplatelet at 6 months and keep him only on anticoagulation given the superior benefit of anticoagulation in these situations. He's supposed to come back to my clinic in 2 months' time, and this is the plan I wanted to do. Thank you.